Hello and welcome to this very special edition of Medically Speaking. We all know that the second wave of COVID-19 has waned. We are all preparing, extremely worried about the third wave. But what about those who have recovered? What about the recovered patients? Can they completely keep that dark chapter when they had COVID back in the past? Or could there be some long-term COVID symptoms, some diseases associated with COVID, or perhaps which could happen because of COVID, which could affect them in the long term? One of those diseases, of course, which everyone's talking about nowadays, is something known as bone death. What exactly is bone death? How can we prevent it? Can we prevent it at all? And is it linked to steroid use, as many studies are now suggesting? To discuss the same and more, I have a phenomenal panel of experts with me, starting with, of course, Dr. Yash Gulati. He is one of the youngest, actually the youngest recipient, Padma Shree in his field. He is a senior consultant, spine surgery, joint replacement surgery, of course, his forte. Attached with, of course, with the Apollo Hospitals. I have Dr. Nikunj Agarwal from the Max Hospital. He's a senior consultant, orthopedic, and also joint replacement surgeon. I also have Dr. Siddharth Shah. He's from Maharashtra, senior orthopedic, and also joint replacement surgery. His forte. He's himself, I believe, seen many patients of bone death coming to him. We will take this further, discuss this in detail. But first of all, let's get to the basics, Dr. Gulati. Help us understand what exactly is bone death. There is a lot of fear, curiosity around it. But for a layman, simply if you could explain to us what exactly is bone death, and is it at all possible to prevent it?
I'm very amused with the definition bone death. This is a new term which has been coined recently because of the increased incidence of what we call as avascular necrosis. See, what happens is that this happens most common in the thigh bone upper part. As you know, the thigh bone or the femur bone has a ball which rotates in a socket. Now, this particular ball has a very peculiar way of getting blood supply. And if this blood supply gets damaged, some part of the head of that ball can get damaged and ultimately loses blood supply, start dying, as you said, and then starts collapsing, and it leads to arthritis in that joint. Not only in hip joint, but also in some other joints, these kind of things can happen. And there are many causes of this disease, or what we call as avascular necrosis of the bone, or what you now call as bone death. Shoulder joint is one, femoral head is one. Sometimes even in the knee bone, the knee bone can go into necrosis. So, but the commonest area is the hip bone or the femoral head or the thigh bone head. So, steroid is one of the causes, very important causes. Other causes are people who have been taking alcohol for a long time, some deep sea trauma, many other causes. Or in fact, the commonest would be fracture around the thigh neck bone. After that, that is a very common scenario. So there are many causes. But in today's scenario, you are right that today's scenario, steroid intake would be the commonest cause. But what can you do? If you need steroid for saving your life in COVID, you have to take that. For example, sometimes steroid have to be given to many kidney patients, or they have to be given to some arthritis patients in rheumatology. So they have to be given because there was no other choice. We try to avoid steroid, but when it is life-saving or some other thing saving, then we have to give it. So the side effect in those cases can be that you can develop what is known as avascular necrosis. So if it is caught early, sometimes you do smaller procedures where patient can get better, but there is no predictability. There is no guarantee that if you do something to get better, or in the end stage, we may actually have to change the joint. So
sir, since you speak of early detection, and I would like to take that forward and bring in Dr. Nikunj at this point of time. Yes. So the question, which comes to my mind is that how is even a layman to know that they need to get themselves checked for avascular necrosis, or, of course, something which, as Dr. Gulati also said, very commonly nowadays known as bone death. It's fairly unknown. What are the symptoms? What should one watch out for in their recovery stage? And when should they ring an alarm bell and perhaps reach doctors like you?
Perfect. So that's a very important question, and the right information should be given and should be taken to the population in the general masses. First and foremost is, as we know, that corticosteroid intake is the most common cause of avascular necrosis, or commonly known as bone death these days. So if the patient has a history of prolonged steroid intake, whether due to COVID conditions or due to any other conditions, so he should have this thing in his mind that there could be a possibility that he may or she may be developing avascular necrosis in due course of time. Coming on to the symptoms, if the patient develops, if we are talking about hip, because hip is the most common cause of developing avascular necrosis, patient usually starts developing hip pain in the early stages, and that usually is felt as a groin pain, sometimes referred down to the knee in front. So usually pain is the first symptom that patient usually suffers. And if the patient has a background of steroid intake or background of COVID disease with a prolonged admission or a steroid intake, then this should ring a bell in his head, thinking that there could be a incidence of avascular necrosis setting in, and then that is the time when he should meet a specialist and should go ahead with some required investigations. Later stages, in late stages, if the patient tends to ignore the early symptoms, then gradually the stiffness comes into picture and the restriction of movements of the hip joint and the gait becomes difficult. But I would certainly say that pain is the first and foremost symptom which patient should look out for in the background of a prolonged steroid intake, which should ring a bell in the patient's mind.
All right, fair enough. And Dr. Shah, since you yourself have treated many patients who were coming with avascular necrosis to you, tell us a little bit about your experience, what it was like. Did the patients themselves, spotted some symptoms and came to you, or were they just shifted perhaps, by the general physician or whoever was treating them for COVID? Tell us a little bit about your experience of what you have seen in the past few months.
Thank you very much for having me. So the cases of avascular necrosis in patients who have recovered from COVID-19, we are seeing them with an increased frequency. All these patients, they have come to me because they had symptoms. Symptoms, as Dr. Nikunj has already pointed out, patients typically, they come with pain around the hip region, which is in the groin, or it could be in the buttock area, or sometimes in the upper part of the thigh. Some patients are unable to take weight on that leg and they are limping, so that is why they come to me. However, I have not had any, all patients have come to me because of the symptoms. So that is the profile. Most of these patients are men. So avascular necrosis or bone death most commonly affects men. In fact, data shows that it is 8 times more common in male patients as compared to females. The age group that I have seen these cases is between 20 to 55 years of age. So it's quite a wide age range, but it is very typical with what generally patients with avascular necrosis would present with. And as we know that the most peculiar feature is that all these patients were administered steroids during their treatment for COVID.
Right. So, Dr. Gulati, since all of you are unanimously talking about steroid abuse, the question is that what does one do? You rightly said, if it's life-saving, one should take steroids. Then there is no option. But, in the last wave, we did see a lot of people take Midrol. I have friends who took Midrol because they felt a slight lung pain, from their, and it was the general physicians recommending it, not just Midrol, other steroids as well. Take us through really why people need to be wary of steroids, and is it required at all in mild COVID cases? Should a person wait till it's severe?
Look, this is a very important point you're bringing out. See, steroid is a wonder drug, actually. It is excellent when it is used, and it is very bad when it is abused. Unfortunately, during this pandemic, steroids were also abused, not only used. In a WHO study, it said about 60% of cases in India, steroid was not appropriate. So that's a large number. So the thing is, because everybody, all and sundry, gave steroids, and not knowing when to give it and when not to give it, was it to be given on day 1, was it to be given on day 5, 6, or was it to be given later? What is the dose required? There was no standardization. There isn't, because it was such a panic state at that time. People were dying left, right, and center. So people had to innovate at that time. So we can't blame. So it is unfair for a study to say that it was misused in some situation, because the situation was so desperate at that time. So in a desperate situation, desperate measures were required. But we know that steroid use is excellent when indicated, abuse is very bad. So we have to be very wary of using it when it is not required. So that is why in general public, generally the steroids have a very bad press. If I tell somebody you take steroid, oh, steroid, no, 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 no. Sometimes it may be very important for that person. So we need to educate people that if required, it has to be taken judicially, at judicious time, in a judicious dose, and
Right.
be given by the right people. And not, I see so many prescriptions, Medrol written even for back pain, even for leg pain, just at the drop of the hat, people give steroid. That's not right. So
Yeah.
people need to be educated that misuse or abuse is not good.
No, I agree with you because I personally also had COVID about a month ago. And I was recommended Tamiflu, which I didn't need at all. And, in fact, I over medicated and that got me sicker. Otherwise, my COVID was quite mild. So, with a personal experience, I
That's
agree with
very
you, sir.
difficult to say that because you see, this in this COVID, I've seen some of my relatives die, some of my friends died. It
Yeah.
changed from looking nothing to death very suddenly. So people have to take preemptive measures. So what now may appear that you are over medicated might have been the right thing to do at that time. So it's
Perhaps.
a very desperate. It was a very. I mean, I've lost my very close friends. In spite of steroids. So that was a very desperate time. So although I was
Yeah.
not directly involved in treatment, but we all hear stories about it.
Right,
Yes.
I agree with you. And Dr. Nikunj, since we're speaking about steroid use and abuse, you mentioned that if any patient has a history of steroid intake and then they start feeling leg or joint pain or hip pain post-COVID recovery, then they should approach you. But perhaps what about those who don't have a history of steroid intake at all or very minimal, and this is the first time when they were given steroids for recovery from severe COVID? What would you say to them?
Yes, very good question. So, as Dr. Gulati rightly said, that steroids were more of abused than used during these COVID times. There were a lot of miscommunication and misinformation which was there in the masses regarding the use of steroids, when to use the steroid and what is the right time and what is the right indication. In fact, when you go to the peripheries, I keep getting patients from more from peripheries, from tier 2 and tier 3 cities, where they have been given steroids right from day one of COVID, and they were given steroids right up till 21 days. So such kind of steroid intake is more of abused, because this is certainly not an indication for the use of steroids for COVID disease. So if in our usual routine OPDs, such patients routinely come. So such history should ring a bell that yes, these people have used a steroid for quite a prolonged time, and probably these with the background of hip pain or joint pain could be suffering from avascular necrosis or bone death. So, and we should be wary for these patients.
Right, and you speak of tier 2, tier 3 towns. Dr. Shah, it's very interesting. A lot of cases came from Maharashtra. Any particular reason for that? I don't know. If not, that's fine. Also, the patients which you saw personally, did they also have a history of steroid abuse, or did they also were they also administered steroids? Was that one of the reasons why they had AVN in their post-COVID recovery phase?
So all the patients that I have seen, yes, they did. They were administered steroids during their for their recovery from COVID-19. However, generally speaking, the cases which I saw, I do not think that there was any suggestion of abuse.
Okay.
However, I do agree with all my co-panelists that of time and in the lowest possible dose. It is known that the total cumulative dose of steroids increases the risk of AVN. So the lowest dose for a shortest period of time is most likely to reduce the risk of AVN.
Right. And Dr. Gulati, is there anything we can do to prevent it, or is it just unpreventable, bad luck? You have to take steroids, you take too much of it as recommended, and then it's a huge possibility that this could happen, because there were reports that 20% people were at risk of getting AVN, especially in the second wave of their recovery.
Well, as we said right in the beginning of the program, and you also reiterated the same thing. What is more important, life or avascular necrosis? If somebody says that you can die if you don't take this medicine, I will take it. And steroid is kind of a very strong anti-inflammatory, but it had to be taken at a particular time, not when the viral load was high, but when the immune response had kicked in on 5th or 6th day. That was the time to be taken. I mean, we don't know. The third wave might come, so we have to be, again, very clear as to when steroids to be taken, how long it has to be taken. But if it has to be taken, I mean, it's kind of a thing. We take so many drugs which have side effects. There's hardly any drug without side effects, but we take them because we have to weigh the risk-benefit ratio.
Hmm.
But as far as possible, we should avoid when not required. We definitely, and other important thing is that if you go to the market, if you go to many, so-called quacks, lot of their medicines contain steroids.
Hmm.
And sometime in general public also people give steroid like children. So, that is what has to be stopped. Life-saving thing, of course, it is important. And also we must remember that alcohol also is a very important cause of avascular necrosis. So
But
you
that would
cannot
be, sir, that would be alcohol abuse over a period of time,
abuse over
correct?
a period of time. But then if that and this and everything combined, you're talking about a lethal combination. So all these things which are, so to prevent, what we can do is not take something that is likely to cause it. And of course, if we can diagnose early, then maybe we can sort of take it easy for some time, or sometimes we can do what is known as a small drilling, or give some, some drugs which are anti-resorptive. So some therapies may be done in some cases, not guaranteed. Some improve, some don't. We don't know why some improve, why others don't, but at least an effort can be made to prevent major damage. So to
Okay.
prevent joint replacement. So early
So
diagnosis.
early detection.
Yeah.
Correct. Early detection is key. Dr. Nikunj, would you agree? Early detection, that's key. And what happens if someone, perhaps it's just diagnosed much later? Then what happens?
So, as rightly said, early detection is the key for the successful treatment of avascular necrosis. And the earlier we detect it, the less invasive we have the treatment for and complete treatment for that patient. So, if we diagnose it in the early stage, we can, as Dr. Gulati rightly said, we can do minimally invasive procedures like some drilling or some smaller surgeries to get rid of to decompress the head, the ball, and ultimately patient gets relieved. But in late stages, as you're asking, if there is collapse of the ball or there is development of arthritis, then we have to change the joint. And there have been incidences where the patient have reported to us late, and patients as young as 35 to 40 years, they report to us quite late in the disease of avascular necrosis. And in such patients as well, we have no other choice left than to change the joint, and we have to go for a total hip replacement surgery in such patients.
And Dr. Shah, what was your experience like? What was the treatment which you administered? All the patients you saw personally who were coming to you with AVN. I hope they all were easily cured with lesser invasive procedures.
So first of all, I would like to reiterate that early diagnosis is key. Now, often what happens is patients sometimes may feel that initially the pain could be just because of some sprain or some minor issue, and then they don't seek medical attention. So I suggest that those who have recovered from COVID-19 have been administered steroid. They should have a very high index of suspicion. If they have any symptoms, they must seek timely treatment. Secondly, as doctors, we should also have a very low threshold for investigations like MRI, because in early cases, the X-rays of patients are going to be normal.
Okay.
Because MRI is what is going to pick it up early. So this will help us make a diagnosis in time. Now, if the diagnosis is made early, we would be able to treat these patients with medicines or surgeries other than joint replacement, which are less invasive and which help to protect the patient's natural hip joint. However, in later stages, when the joint is completely damaged, there is no other alternative than a total hip replacement. So the patients who have come to me, I would say nearly half of them, they already had advanced disease and there was no other treatment option other than a total hip replacement. However, the other ones, the other half, I have been able to manage them so far with the help of medicines, certain special drugs which Dr. Gulati pointed out, anti-resorptive drugs like bisphosphonates, and of course, apart from that, patient is advised rest and not to take weight on the affected leg. So obviously, this is something which will have to be followed up, and only time will tell how much of them we are able to delay or halt the progression of disease.
Right. And Dr. Gulati, Dr. Shah, and all of you, of course, have spoken about early detection. Detection via MRI. Would you suggest that? Because there is a lot of fear in people's mind when it comes to CT scans and MRIs. Is an X-ray not really enough to detect early AVN? or should they right away go for an MRI or a CT scan?
Yeah, if you're seeing it on X-ray, it's probably quite late already.
Yes.
So it has to be diagnosed much earlier than that. But see, it's the symptom, the pain. That I mean, I don't want to spread scare in the society. And there are so many people who are affected with COVID, and so many people are taken steroids. So there's nothing to be so alarmed about. If somebody who has pain, somebody who has limp, somebody who's starting to have pain in the thigh or in the hip or pain being referred to me, just goes and sees his doctor, gets examined. Usually there will be some mild restriction of the movement and you'll do a scan and find out. So there's nothing to panic about. If there is a symptom, just go and see your doctor. If there's no symptom, live happily.
I'll tell you why I'm asking this, sir, because, this comes to my mind. If I personally had a thigh pain and, the bone death was not discussed highly in the media as it is right now, I would have ignored it. Like, a slight twitch or a slight, sprain or pain. Who would take it that seriously to actually go for an MRI or a CT scan? I mean,
that's what you are here for. That's why you're doing it. That's your role. You are fulfilling your role, aren't you? So it's very important that you see anytime a new thing comes or it comes in a larger number or something which needs more public attention, that's what media is meant for, not for some silly debates we see. This is your role. This is the important role.
Unfortunately, it takes a lot of our time. That unfortunately takes a lot of time. But Dr. Shah, did you have patients who were, did you recommend an MRI CT scan right away to your patients, and did they have any apprehensions at all?
So yes, MRI is what I have recommended to my patients whenever I suspected that this could be AVN, and I did discuss with the patient in detail. I explained to them, and once we explain them, usually there are no more apprehensions. Initially, yes, some people are a little concerned that, doctor, what if it is just a minor sprain or a twitch, and do we really need to go for an MRI? But once I explain to them, they are usually ready for the scans.
All right. And Dr. Nikunj, is there any age group? Does it affect, particularly we were talking about even how AVN can affect 30 to 35 years old. Take us through, a basic age group which could be more susceptible to AVN in this post-COVID recovery, because that's the really, niche area which we're focusing on as of now.
Right. I think that is very important to understand. So AVN or bone death, as it is commonly called these days, most commonly affects the younger age group. And most commonly in the age group of maybe 30 to 55 years of age group is the main age group which the people get affected with avascular necrosis. In fact, in our routine OPDs, post-COVID patients, which we normally see with the prolonged steroid intake, they usually come within this age group with a hip pain in front, referring down to the knee joint. And as rightly said by Dr. Shah and Dr. Gulati, MRI should not be routinely recommended to the masses, but it is only the pain which should be again emphasized to the general population, that should be the first clinching factor with which they should come to the doctor and the specialist. And after proper examination, then we can recommend MRI if required for post-COVID patients who have taken long steroids.
All right. And Dr. Gulati, speaking of treatment as well, who are those patients who would require a replacement surgery altogether? What would be the stage in which a replacement surgery would be needed? And before that, what are the treatments? If you could explain us again, in simpler layman term, on what type of treatment can a person get if they are indeed detected with AVN?
Can I just point out one more thing before I go for this answer?
Absolutely.
One is we were talking about MRI and all, why people are scared. See, MRI is not like CT scan. MRI doesn't have radiation. So except in the first trimester of pregnancy, MRI is quite safe. So people should not be apprehensive about it, unlike CT scan, etc., which has a lot of radiation. So, that's an important point. As far as the treatment is concerned, now it will depend on the stage. In early stage, even just offloading, weight bearing, etc., giving anti-resorptive drugs, for example, alendronate, initially intravenous and then orally later on, has been shown to give good results. And then if it is not working, or even early, one can do what is known as a core decompression, drilling holes, hoping that the blood supply will get re-established to that. There are also cases of where we can concentrate the bone marrow and put that marrow into that area. And some people like to call it a stem cell therapy. We call it a bone marrow insertion into that, and that also works quite good. Now, joint replacement is the end stage treatment. And this is, I often say in my practice, the decision about joint replacement is 60% patient and 40% mine. The patient will tell me, Doc, I'm fed up now, you do something for me. That is the right patient to do joint replacement. You see the x-ray, you see many x-rays, sometimes they look not so good, but patient says, I'm fine. And sometimes the x-ray look fairly okay and patient is a lot of pain. So pain. Coupled with findings on the x-ray, if there is a head collapse, there is pain, disability, difficulty in walking, and patient says, look, I cannot do my day-to-day activities, I cannot go to market, I can't go to work, I disturb my sleep, and I'm having to take painkillers regularly. That is the patient to have replacement. Now, unfortunately, this disease affects younger people, as Dr. Nikunj said. So every joint replacement has a life of its own. Maybe 10 years, 15, 20, 30, some cases 25, 30, but on an average, say about 15 years. So if you do a replacement in a 30-year-old, there are very high chances that you will need another surgery around 45, 50. But if you do it in a patient who is 70, then the chances are, well, that he will go with him. So we try not to do it in younger people, but if the disability and pain is high, then there is no other choice but to do it. So it is a very fine balanced thing. And I again tell the patient, look, it's 60% your decision. I've seen your x-ray, the x-ray doesn't look good, it needs treatment, it needs surgery, but if you're coping, we'll hold on. You know, whatever time you save now will be the time that you save later in your life. So this is the counseling that I do, but again, pain, disability, that is the indication for joint replacement. And these days we have very good, sophisticated, uncemented and, ceramic and all those things which are available, which are likely to last long. But one has to be very judicious in taking a decision like that in a relatively younger person.
Right. And, Dr. Shah, since you were talking about your personal experience, how you had to go for surgery in a lot of patients, just take us through really what had happened, what was the average age? Were they, again, as Dr. Gulati is also pointing out, were they a little more elderly, or were they all the AVN patients which you've seen in the last few months, were they all, the younger generation or the younger people recovering from the COVID disease?
Right. So the patients who were recommended hip replacement, they were slightly on the higher end of the younger spectrum. So they were above 45, 50 years of age. So I agree with what Dr. Gulati has said, that a hip replacement has a finite life. So we are concerned that after a certain length of time, it may have to be changed. And here again, I would like to emphasize that is why timely diagnosis is essential, because if this problem has been diagnosed early, then we can resort to other treatments which will help prevent progression of AVN to a severe stage where a hip replacement becomes inevitable. So, as I said, the patients had been at the higher end of the younger spectrum. So, but because they were in severe symptoms, and again, I did go by what how disabled they were, and that is why a hip replacement was offered to them. And because with the newer materials, we can offer them a life of about 25 years, 30 years. So that should be a reasonable treatment option in them.
Right. And, we're running out of time. It's been a very riveting conversation. So I'm just going to give a last word to all of you. Dr. Nikunj, what will be your last word, based on what we have discussed for people who are perhaps watching it?
So my message to the masses would be that, first of all, you should have a high index of suspicion for those who are having joint pain, especially hip pain, as we have discussed, and with the background of a long steroid intake during COVID-19 conditions. So such patients should go for early detection by referring them by going to the specialist and getting the right investigations done so that they can get treated at the right stage with the minimally invasive techniques, rather than getting picked up at the later stage and ultimately going for a joint replacement surgery.
Right. And Dr. Gulati, final word, any word of advice?
My word of advice is that don't panic, and let's not even spread panic in public, especially those who had steroids and all. Very small percentage of these people will get avascular necrosis, very small percentage. So not to panic, and if there are symptoms, go to your doctor and discuss it and do the right investigation and diagnose it early. And as far as the steroids are concerned, make sure that you are getting a judicious dose, discuss it with your doctor. Is it important? What is the time to be taken? How long to be taken? And be very wary of the drugs that you're getting with some of the quacks. So please be very wary and go to a qualified person when you are doing the treatment. I hope the COVID doesn't come back. For God, I pray to God. Just in case something third wave comes, so we'll have to be extra careful and use steroids. Again, pray to God that it doesn't come back. And even in other spheres of life, other diseases, we should use steroids judiciously, because when used properly, they are wonder drugs. When they are abused, they are very bad.
Right. And Dr. Shah, finally, word to your word of advice. I'm sure you resonate the same feeling on early detection, because that's something which I have seen you all reiterate throughout this discussion.
Yes, so absolutely. First thing is, yes, one must not panic. One must always take treatment under medical supervision, and timely diagnosis is key. And hence, one must, the moment there is onset of any symptoms about the hip joint, do seek a specialist orthopedic surgeon's opinion for further treatment.
All right. Thank you, doctors. Thank you for joining us. It's been a rather riveting and interesting conversation, and I really hope it's helped you viewers. We hope that the intention was for us to be informative. I really hope that it does help anyone who perhaps has these symptoms. If you do, as the doctors have time and again this discussion reiterated, early detection is key. If you do feel any symptom, do not panic. Just go to your doctor, refer to your doctor. They will guide you ahead. Thank you for your time. Thank you, sir.
Thank you.
Thank you very much.
For more such videos, subscribe to the NewsX YouTube channel, hit the bell icon.